Everyone, welcome back to another episode of the Scrubbed In Show. This week we have with us another incredible guest. We have with us Professor Sultan Mahmud, who is the Director of Healthcare for BT. Yes, BT. You're probably wondering why on earth he's on this show. Prior to that, this probably make more sense. He spent 2 decades in the NHS in various leadership roles. And another kicker, he was a Chief Innovation, Integration and Research Officer at Royal Wolverhampton. I have no clue what that means. I imagine a lot of our listeners don't know what that means, but absolute pleasure to have you on the show, Sultan. How are you?
Very, very good afternoon, Abdul and Ams. Very good to see you and very delighted to be here. I'm well. I'm well. Thank you.
So we tend to start kind of your career journey, where you are now. You're super accomplished. You spent, close to 2 decades in the NHS. You've seen a fair bit, but tell us kind of the early days of Sultan, as you're embarking on this career, was it marketing, was it media, was it innovation? Kind of bring us up to speed.
Yeah, sure. I mean, I spent kind of near on and off 26 years in the NHS, so it's kind of over 3 decades. Yeah,
Oh, wow.
if you think it
Wow.
through. So, look, my background really. So I started off in big pharma. I was a management person at GSK. Started my career there in regulatory affairs, and that was based in around London. Yeah, and for a young kid from the Black Country in the Midlands, it was a big old city. And whilst the company was absolutely privileged to work for, I knew that I wanted to be close to home, closer to my kind of elderly parents and kind of wider responsibilities. So I moved back to the Midlands, and the NHS, it was my first job. Yeah, and it was I started off as a data analyst. Yeah, because I was good with numbers. I enjoyed kind of understanding what the impact of numbers could be on kind of delivery and kind of planning and things like that. So I started off in the NHS as an analyst, and I did various jobs really across, in commissioning. I worked in planning, health protection. I did a bit of work in contract management. Then I moved more senior into kind of senior commissioning roles around kind of service design and delivery, and kind of interlocking with the provision sector. And I thoroughly enjoyed it. The kind of being the glue that knocks the system together. So in those days, there were kind of health boards, health authorities, which then turned into SCGs, which turned into PCGs, sorry, which turned into PCTs, then changed to CCGs, and it's a constant reorganization every 2 years. The fixed points in the NHS, if you like, the doctors and nurses in primary care and in the provision sector, in acute and community and mental health, that kind of stays reasonably static, and the other parts keep getting reorganized. So that's kind of my abiding experience. So, but essentially that was the start of it. Then I moved into the acute sector, which I found to be really dynamic and really, you really move into the sharp end of things, because you can see the ambulances outside, you can see the car park being full, you can see what the on-call rota is, you can see kind of how many people you need to kind of see and discharge to get through the night. So I worked in a large organization, and that experience held me in good stead, because that's really when the exposure started with direct patient care. And there's no substitute to kind of dealing with kind of live operational issues in a setting like that, as well as kind of having to interlock with the wider system whilst trying to deliver your own kind of objectives in a provision organisation, but having to kind of work the processes, the business, the politics of the system, and still trying to kind of do the best thing for patients. So I did kind of, that for a few years. Then I moved into a system management role, because I wanted to see how it works at the higher level. So NHS England, I was fortunate enough to kind of get a large region, and I had the control of direct commissioning of 450 odd million pounds. And that included kind of primary care and specialised care, many other things. And I did that for a couple of years. And whilst I enjoyed it, I think I missed the cut and thrust of being in the acute sector, moved back to the acute sector, but in a different role, in terms of, we were very clear that the care pathways needed to change, that the model was a reactive service, so we need to think further upstream. So we developed kind of integration philosophy before it even became fashionable. And we were the first trust to successfully integrate a large section of primary care into the organisation. They, the primary care colleagues became part of the organisation, received all the benefits of having all of the, if you like, the governance and the finance and the kind of back office functions supporting them, so they could focus very clearly with their consultant colleagues in secondary care around longer term conditions. So that was the theory of change, and it was very similar to the kind of models you will have heard of, such as Kaiser and things, where there's further integrations. And then moving on from that, once we kind of landed that, and that started to produce some really good outputs, some published information on by Rand, and kind of good peer-reviewed studies around kind of impacts on non-elective admissions and patient satisfaction and primary care access. Moved into kind of what I felt that where the world was going, which was digital and transformation. So I kind of took that kind of lead role in that as a kind of the board director responsible, and that encompassed everything really. And where we tried to do it differently was understand that industry is really important, and to work with industry and the expertise that they have is absolutely a must. But at the same time, kind of be really clear about our problem statements and what we want to achieve for our patients. And also, it was an ability to attract inward investment into the NHS, because we had really good data sets that comprise primary, secondary, and community services care in real time. We were probably one of the first people to do that and use it on a kind of, if you use it before population health became a thing, right? First acute trust in the country to have a public health department and a primary care department in the bowels of the hospital. So the hospital, wasn't just looking inward, it was looking outwards and sidewards and upwards and downwards. So a really interesting role. And then, because innovation was important and R&D is important, I mean, we saw how important R&D was. The NIHR did a magnificent job during the pandemic. The public lost a bit of a sight of that, but really it was the NHS doctors and nurses that developed a lot of the kind of the data and the science behind the vaccines, which was a successful rollout, and that sometimes lost in translation. So I ran at that time the largest clinical research network for the NIHR, which gave me a kind of a broadened out experience, and it was probably one of the best performing in the country as well. So a really broad brush experience, kind of strategy, operational stuff, system management, R&D, innovation, digital. I've had what they call a mongrel of a career, and it's been the privilege of my life serving the NHS. So that's my kind of NHS background.
Perfect. I think that lays the groundwork as to who you are and kind of the various roles you did. Going back to that journey, the first question that comes to mind: how was the transition from the private sector, Pharma, GSK, let's say unlimited budget, to then working in a public sector, NHS? How did that transition feel?
Yeah, I mean, I just want to underline, I was really reasonably junior at the time. Yeah, so it's my first job, but immediately you saw the kind of difference in resources and the way people were managed. I felt that certainly Pharma really, first of all, they really look after their staff, and people are valued. There were great statements like "disease has no greater enemy." There's just a huge emphasis on kind of people and looking after people, because people will deliver results if they're looked after. That's just a universal rule, right? Yeah. The NHS staff survey is nothing more than that, just trying to get a temperature check on that.
Yeah.
So that was the first thing. The second thing was kind of the focus and the drive. Yeah, I think there was joint commitment. I mean, my foray into the NHS, I certainly saw commitment. People really did want to kind of make a difference. But I suppose the business processes were sharper and slicker and faster. And it was a well-oiled machine. And it was for me to kind of understanding that and saying how much of that can we kind of pinch with pride, essentially, was my thinking. And that was a difference in terms of kind of just tonality and speed, yeah, and focus and drive. In terms of the talent in the NHS, I mean, certainly, my first impressions were the clinicians are still very, they're some of the brightest people on the planet, and especially, we are fortunate enough to have the best trained, and you guys know this. I'm quite subjective, but we have the best trained clinicians in the world, or amongst the world, right? So. That's the first takeaway, yeah. And I just thought, my first question, it was early days in my management career. It was like, are we putting the right conditions for these Ferraris to kind of really motor? And that was kind of a bit of restlessness inside me, and I was kind of challenged where it was appropriate. But those were my kind of overriding kind of impressions. So commitment on both sides, but different skills and strengths and weaknesses.
You touched on clinicians, consultants. As clinicians, when we're kind of on the shop floor per se, when we're on the wards and we're being pushed to do discharge letters, we're pushed to kind of get that flow moving, see more patients. We always have a dig at people like yourselves, right? People in the suits, the boots, and the nice fancy offices. What do you want to say to the clinicians listening to this, where they don't trust management, they've lost faith in management, because you're not there, you don't know what it feels like. If you had an opportunity to go back to them, what would you say to those clinicians?
Look, I think it's hard. I think it's dangerous when we make blanket statements. So I think from what I've seen, right, this is all about human relationships. Yeah. So I think everybody will agree some of the systems and processes are sometimes custom and practice and probably not the best process. Yeah. The art of the change, if you like, is the change management is on triumvirate of people from clinical staff to operational management, leadership, as well as kind of wider support staff. I have kind of done those calls, and I've been director on call for many years, and I've kind of had to pick up the phone and say, kind of, we need X amount of discharges to get us through the night, and it's the forecast for tomorrow is not looking good, and all that kind of stuff. And actually, largely, clinicians were amazing. They responded positively. I do understand what you're talking about, because I've had that question asked to me, and it's all down to investing the time to have a discussion, and say kind of, because clinicians are extremely bright people. Nurses and doctors in this country are bright, and actually explaining the rationale is not going to be lost on them. The way we do it, and thinking through the alternatives. I think if everybody thinks through the alternatives, look, we've got to get through X amount of discharges to get through the night, but clinical safety is always going to override everything. So you guys have that card, if you like, and it's the right thing that you have that card. But I think where the rub is when the conversations don't happen. So say we were on call together and I kind of gave you some jip and saying we need some movement, guys, and it's difficult, and I'm getting asked for diverts from two other trusts and whatnot, and it's challenging, and and if it was a bad experience, what leadership is about is actually say that was a bad experience and acknowledging that it was, because acknowledging something difficult and not right is really important, because unless you acknowledge something, you can't really resolve it. Then having the mature adult conversation, right? What was good? What was bad? What can I do? What could I have done differently to make you, who are kind of treating my friends and family in the community, your job a bit easier? And I think that's the bit, where's the social space, or the capacity to have those conversations? And the organizations that do this really well, the culture sets the tone, really. And there's some amazing examples of positive culture around kind of how clinical and managerial cohorts work together. Amazing. So I would disagree, Abdul, around clinicians and kind of managers and the suits don't get well. In some areas they get on really well, and it's a team sport. But for young clinicians coming up through the system, or young kind of management trainees, and we have excellent management training scheme, is let's have a conversation about when things don't go well and what can we do differently, and how do we feed that up to our kind of normal channels. But as you know, most big organizations work on informal channels. It's the stuff that's not written down, and that's constantly evolving, so it's on all of us to keep rewriting that stuff.
Absolutely, I agree with you.
To talk a little bit about now sort of the engagement of clinicians and management and overall operational goals, right? So we know that one of the major stressors on the NHS is the flow, is the load, is the growing stress on the NHS. Now, where do you see the future? Because we haven't reached proper December, January, February period this year, and we're already seeing a lot of strain on the ground as well. All of my colleagues, there's a bit of stress that's brewing about what's to come. With the NHS, do we think we can carry on like this? What's your opinion? And this is just obviously just hypothesizing about the future, but what do you think in the future, what's going to happen?
So I think, look, whatever we say, we need to acknowledge a few things. So I think it's universally accepted that the workforce is an issue, the level of vacancies, and the funding required to kind of, to get that to an even keel is absolutely, it's a must. It needs to happen. Our teams, our clinical teams across the NHS have come through a pandemic, and they are on their knees. I say kind of. working on fumes, essentially. Yeah. So the first thing is to acknowledge it's a really difficult task. Yeah. Now, the workforce needs sorting out, but there's things that are amenable and addressable. So to answer your question very bluntly, I don't think it's sustainable future unless we address the workforce.
Yeah.
Then there's the care models that we need to think through. So we are now accepting care that we wouldn't have accepted 5 years ago, 10 years ago. 12-hour trolley waits are becoming
Yeah.
increasingly the norm. So I think there is general acceptance that kind of care is below the standards that we, people want, are the people we serve, but also the NHS. We're normalizing poor care, so that needs to be addressed. So it's not sustainable because no one will, the clinicians won't accept that. So the care models need to be changed. So going from a national kind of reactive sick service, and it's, we call it the NHS, but it's actually the National Sick Service, because we respond and react, and that's wonderful skill to have, and we should retain that. But it just can't be everything. Yeah.
Yeah.
To move to a national wellness service, the care models need to change. And we've heard this, all of you will have read hundreds of papers around the demography changes, the number of people who, with multiple comorbidities who are kind of 65, 70, 85, however you cut the cohort, are going to kind of double and treble in the next generation. So the demand is going to keep coming and the workforce will never catch up. Yeah. So the onus on us is we have to move care outside the confines of the hospital. Yeah, wherever possible.
Yeah.
And this is the opportunity, because moving to an anticipatory model, requires bravery and requires kind of us to kind of think differently. The whole integrated care agenda, the ICS is kind of, that's the theory of change. The execution perhaps is still being worked through, but that's what the intention is. To make that happen, I think the opportunity is with technology. So you can use technology for many things, not just the tech itself, because the tech is certainly there. I mean, let's make no bones about that. The tech is there to kind of manage this. It's the systems and processes that need to underpin it, and the care pathways needed to, you can't just put tech in and not change the clinical pathway, right? So the digital pathway, if you like, and the clinical pathway need to change together with the right technology and the right kind of integration and orchestration mechanisms. Yeah, that needs to happen, because with that, there are some benefits. Anything that we can take the load of busy clinicians like yourselves, and kind of manage in a different way, that gives you more time to care, and manage, and importantly, the experience of delivering care should also be a metric. So if you guys are feeling like, oh God, you've had 12 rounds with Mike Tyson every day, that's just not sustainable. And for patients to get the best outcomes, that anticipatory model needs to take precedence. So that needs to happen really clearly. And there are lessons in the Nordics that we can pick up, around how people have done that. There are lessons in many other countries. The New Zealand models talked about, I've mentioned Kaiser, there are other countries where they've started to do this really well, and we need to just pinch with pride, I think.
Kind of moving on, you spent a long time in the NHS, you kind of worked your way up, senior exec positions, actively creating positive change and culture. Tell us a bit more about this opportunity with BT, what the role entails, how did it come about, and, the rationale for making the switch back into kind of the industry per se.
Yeah, it was a kind of deeply personal. I mean, I had some very bad news on a personal basis, and a dear friend of mine kind of passed away essentially. Prior to kind of his demise 3 or 4 years ago, we were having lots of conversations around the future for him and for myself, and as you do with your kind of best mate. And he said something around the NHS and what you've done, and it's great, you really love it, we think it loves you as well. So kind of, it was all great, and it gave me a life. I mean, just to be clear, it gave me a life. The NHS gave me a life I could not ever imagined, coming from very humble beginnings. So I had the NHS to thank for everything, not only my career, but 3 wonderful children, its care of my family, all of that. The NHS, I kind of hold it in high regard. But I don't worship at the altar of the NHS in that sense. So it's great, but we need to kind of call out where it's not so great. Yeah, so that's where my positioning is. And essentially, my friend said to me, look, think about the world outside and think about kind of what's the why for you? Yeah, and is there more? And I knew he was right. I knew kind of, the time was probably right on because of many reasons. And BT essentially picked up the phone and said, look, we are a national company. We've been with the NHS since 1948. We did some amazing things during the pandemic. We stood up the Nightingale hotels, connected ICUs, field hospitals. We do a great job with the 999 service. We, as a company, want to, being the premier communications company in the country and one of the most trusted brands, we want to do better in the NHS, but we want to do it differently this time. We want somebody who knows and cares about the NHS, the people it serves, but also understands kind of how technology can positively impact on operational and clinical outcomes. We want to do better. And I kind of evaluated that, and the chief executive, Philip Janssen, the global CEO, he a very inspiring guy. Kind of his pitch around connecting for good. Yeah, we've got to have purpose behind our jobs, and at the same time helping me broaden my horizons. Those are the two things that came into play, and I needed to know BT was serious, and we tested that over a period of months. And I got to the head. Look, they acknowledge some of the issues, and let's just call it out in the room. The National Programme for IT. You guys are probably too young to remember that, but there were some missteps there, and so the company had learned from its mistakes. It was very committed. The corporate goals and it's around sustainability, how it treats its people, all of that chimed with my values. And I have to say, I mean, in terms of people, I mean, the BT leadership and the BT kind of way of things, it's really, really positive in that sense. It doesn't get everything. It doesn't purport to get everything right, but it's moral compass and trying to do the right thing. It's really important. It kind of encourages all us executives to kind of spend time doing social causes, and kind of gives us time to do that. Volunteering is activity. So all of these things, and an ambition to serve, an organisation that has 10% of the GDP of the country, the NHS, better. I thought, well, I know about the NHS and I know about technology, and these guys have got the right stuff about them, and they've learnt, and why not? And that was it, really. And to start up a fully loaded healthcare vertical shows real investment and real intent, and they did that. So that was kind of the reasons behind it, and so far it's been an amazing, humbling experience, but amazing.
No, thank you for sharing that.
A question about sort of the big tech, the industry partners now. So yesterday I was doing some research, right, about the future of the NHS and how I personally think we need industry, big tech, and everyone involved for the future of what healthcare could look like. Now, from yourself, I would like to also ask you, do you think, we first even need big tech, industry, and everyone involved for the future of healthcare? And can you tell us maybe one or two or three reasons why we do need it? Because when speaking on the ground again to our colleagues or consultants, they will say, no, all we need is the government to just give us a load of cash to the management. It funnels down and everything gets scaled up and it's just pristine from there on. Tell us a little bit why about industry has a role to play.
Look, I think, first of all, the answer is not always give us more money and we'll sort it. Now, funding needs to be right-fitted and right-sized for the challenge ahead, and there are clever people to do that. I mean, I remember you guys were too young, but in 2007, 8, I think we kind of started on 18 weeks. And at that time, it seemed like an insurmountable challenge. But we did lots of equilibrium analysis, and we kind of went through the stages of treatment, and it was a national effort, and we got down to kind of 90 and 95% of people not waiting more than 18 weeks for kind of from referral to treatment. It's a major achievement. It required investment, but investment came with a give and a get. So more and more money is not the answer. Just I want to put it there. Funding needs to be right-sized, workforce needs to be right-sized and invested in, but no one or no country can just keep playing money in. So the second point is the power of technology. So we talked about technology. So I can talk about BT, for example. So BT has global customers. It has customers in the FTSE 100. And we take our customers on transformation journeys. We do amazing work in the world of fintech and kind of major government and other areas. And we take organizations on transformational journeys. And because those organizations, they realize they have a really deep understanding of their pain points, and are not always aware of what the technologies out there that can enable that. Where companies like BT and many, many other companies, we can mention Microsoft, AWS, Google, the SME community, many other organizations have serious, deep expertise in the technology. I think the marrying of that expertise with kind of the operational pain points and the clinical pain points is vitally important, because where the public are in this is that, they are immensely digitized and digitally enabled in most aspects of their life, from their banking to whatever aspect. If you think about your day to day, just think about from the moment you woke up, how digitally engaged you are in all aspects. If you were a customer of the NHS, you're probably thinking, I'm not that digitally enabled. Yeah, actually. Yeah. And in that is the fact that those sectors have engaged with the experts, to come up with the solutions, and then build those solutions and scale them up. Now, because all the knowledge is not on one side, I think the kind of the bilateralism or multilateralism that's needed between academia, the NHS, and the commercial sector is vitally important. The mechanisms are not been great. People are fear about kind of procurement and other things like that. But I can tell you, and I deal with all of these large companies and the SME community in healthcare. We are very adult around kind of, we know that engaging with the NHS does not necessarily result in a contract. But there should, my personal view is there should be a digital strategy for each patch, which there is. And in holding to account of that digital strategy, the best of industry, patients and citizens, and the system need to work together, and hold each other to account. If BT came into a kind of thought leadership space, and the solution was not BT, but we knew that, oh God, Microsoft or Amazon could really sort this, or I know this SME partner, or I know this kind of virtual care partner, or I know this diagnostic partner that could really sort this. We have the networks, and I think it's not always easily available to them. So kind of problem statements need to be kind of publicly available, and the digital strategy public, and that confluence of those three sectors need to kind of work hand in glove, and the governance has to be kind of worked out. Now, France, if you think about what they're doing with the national strategy of healthcare in France and digitization, there's some lessons to be learned. There's something to look at. But think about countries like Estonia. I know it's a smaller geography, but 9 out of 10 patients have longitudinal live rewrite records. Oh,
wow.
90% of those their prescriptions are digitized. All of the patients have access. 99% of the patients have access to their records, but also where for whatever reason it's not appropriate, their carers do, or they're kind of designated users. So there's lots of things to kind of learn from other sectors. The other thing I think is that the NHS needs is that kind of digital leadership, and change management capability. So digital leadership exists kind of in companies like ours and other places, right? Why not tap into that, knowing that we're not going to. We are all adult enough to know that not everything's going to end up in a contract, but you will get that leadership, and then the level of groupthink and dynamism can perhaps be uplifted. So that's another thing. So I think it's really important. Some of the best innovations have happened when you've got the best heads around the table, and I think that's really important. But also we also know the kind of pathway change and digital translation, if you like, is really important. The tech is not the clever thing. The translation of the tech is the clever thing,
Exactly.
right? And implementation journeys need to kind of be funded and supported. And actually, I think even the tech sector can help in that as well, to understand that and how it would do. So there's a lot of expertise there. The NHS is everybody's tax, not just people who work in the NHS, but we all pay tax. So we all want the NHS to succeed. And I think if we're getting the best bang for our buck, I think everybody will be up for the challenge, but I think the mechanism needs to be thought through
absolutely
carefully.
If you just to kind of shed a bit more light, is there an example you can shed about something BT is doing right now that will kind of make sense in how BT plays a role in the NHS? Because for a lot of people, they perceive BT as a telephone communications provider. What's a real tangible thing they're doing right now in the NHS?
Look, I can give you some examples. So, I've talked about kind of the core infrastructure that we ran. We run the 999 service. We connect 35% of the country through the kind of HSCN, Health and Social Care Core Network. So we kind of have a lot of data running through our veins. And the expertise we bring is that kind of big business, B2B capability, trust and assurance. Delivery chops, as we call it in my neck of the woods. what we're doing in healthcare, there are a few things. So, if you think about infrastructure and kind of clouds, from the network layer to the kind of application layer, there is an increasing need to move to kind of hybrid or full cloud into the NHS for various reasons. For sustainability, access and agility of data, data equity, data provision, all of that. So we're working with a couple of health economies. I think, Liverpool's one of them, University Hospitals Liverpool, where we've kind of created a multi-cloud environment that has the capability to kind of onboard 20 or 30 organizations into that, thereby kind of reducing the total cost of ownership, so addressing the kind of gap and returning some money, but also improving access to data. So that's kind of one thing. So kind of cloud infrastructure, I think, is going to be really important, and we're into that. In the more kind of clinical space, if you like, we have a series of partners who we are taking to the market into the NHS in terms of virtual care, virtual ward, and care closer to home. And as we've talked about, we've got to move the dial on kind of care that's outside of the walls of the hospital, but we've got to do it at scale. And what BT brings to that mix is not the SME play, which is kind of a ward here and there, but the ability to scale. And we're working through some areas in that. We have to kind of be mindful to where the country is, 7.75 million on a waiting list. It's sober and it's hard, but also the underpinning stories of those people are heartbreaking. I was on Radio 4 last week and there was a call in, and I was asked my opinion, and listening to 2 or 3 of our own people that are in the country who are kind of going through this, and their complications that have physiological but also psychological, is heartbreaking. So we need to get to grips with that. Now, in the stages of treatment, the thing that is really amenable to tech is diagnostic. So one of the things we're doing is we're applying three-pronged attack on it. So we know that there's really good promise as kind of in radiology around the reporting of kind of scans, and the AI algorithms that are kind of CE or FDA approved are reporting really good levels, 99% upwards, right? And they can kind of segment kind of a take, as they kind of say to the radiologist, who will always be in charge. That's the thing we need to remember. The clinicians will always be in charge. This is a co-pilot. This is an assistant. This is a support measure. To say, look, of the 55, these are the 3 you want to have a look at, and this is what I think it is. What do you think it is, Doc? Now that kind of agnostic platform can sit on top of any PACS or RIS system. So that's something we're bringing out. And again, we're bringing the kind of, if you like, what's around it. So that's clever technology is done by the partner organizations that we've onboarded and got ready and all that kind of stuff. And they are excellent proven record in Europe, particularly in Germany. But if you add the cybersecurity, the business continuity, the connectivity around it, it becomes a really viable proposition. That's kind of something real and today on the truck now happening. The other thing is, as you will know, I've appointed a clinical board at BT. So very senior clinicians who have had buying and operating experience in the NHS. When I say operating, I mean kind of taking tech and making it work, and leadership roles and board roles. And they know the journey that tech must take. So everything we do is rooted in kind of being clinically led and digitally deliverable. And that kind of making sure it works, first of all, making sure it's safe, effective, that it kind of leads to well-led, caring, responsive, all of that is kind of core part of the CQC inspection regime. We're trying to kind of get tech kind of absolutely wound into that. So we have clinicians kind of driving our thinking and saying, no, don't do that. That's rubbish. That's never going to work. That's really important. It's important to rule stuff out, right? Understand problem statements. And they've pointed us in kind of, we need to do something in diagnostics. So that's one example of work doing in diagnostics. We've had lots of impact on patients and their communications, particularly during this hard time. So we've developed a kind of AI-based patient concierge system, which we're really excited about to take. And again, we are a communications company. We're going to help with communication, right? And it will work on any device. And the patient will only get responses. We personalize responses based on the inputs or the kind of source data in the NHS organizations. And I'm really looking forward to kind of taking that out and scaling that across the country. And there's kind of easy things around kind of tech enablement. So if you think about radiology again, there's a global shortage of radiologists, right? if we can kind of expand the workforce and people can kind of access and report on records on their devices, in an information governance safe way, through technology, we can do that. So we have a really interesting technology that kind of delivers the scans on a normal £500 laptop at very high fidelity. And as long as a clinician is kind of linked into the kind of governance system, boom, you've just expanded your workforce.
Crazy.
Yeah. So this is real stuff. This is not fairy tales. This is kind of in the truck right now. Now, how do we as a system then think about how do we kind of rapidly kind of mobilize this? So that's the interesting challenge. That's the interesting challenge.
A follow-up question on quickly about AI. So again, I was really thinking about sort of AI hallucinations and thinking about when we're putting AI into the hands of our patients, have we reached a point of safety already with regards to AI hallucinations, i.e. giving dangerous responses to patients or clinicians even?
So AI, look, it's AI hallucinations. It's kind of topical, right? And I'm not going to delve too much into it. I will give you kind of where we are with AI and where I think we should focus. First of all, I think definition is important because some of it's AI, some of it's generative, non-generative, some of it's large language model based, and some of it's not. I think we can all agree, right, that it's here. So from ChatGPT, right, it's entered the public kind of lexicon. It's kind of in everybody's attention. People use it, whether we like it or not. People will ask ChatGPT, "What do you think this is?" and whatnot. So it's there. And we need to be kind of understanding that the public will respond to this. So our response has got to be really, in terms of industry and the NHS, is going to be really important. So we have very, very strict protocols at BT around kind of how we advance AI, and we will do it on a kind of validated, very high governance way. But let's think about where the opportunities are. The opportunities actually are in non-clinical stuff. Number one, because the regulatory barrier is lower. The ethical framework is kind of more manageable. But if you think about just some examples around, just think about HR processes. How long does it take to kind of get the paperwork done to recruit someone and all of the other things? The machine can do that really quickly with high fidelity. Think about kind of NHS back office. If we are struggling for people, then how much of the roles that we could that the machine can do in terms of non-clinical admin roles that we could do, there's a huge amount there, and other industries are doing it. So I think admin-based, AI and ML-based tasks, we should just do that. There should be a plan, and we should just go for that large. On a clinical footing, right? I've talked about kind of, non-generative stuff. I think there's real opportunities. So kind of, radiology is a really good area. There's the 21 million AI fund, and that's all based on sensible things with good evidence behind it. We need to do that. On a broader philosophical level, look, I think there's a lot of hype. Large language models and their applications are probably a few years away, but I think the opportunity there is kind of, large language models by definition, it's large data sets, interconnected data sets, and the ability to kind of take the source data and do something interesting with it. Population health comes to mind. Resource and business planning comes to mind. If you think about how systems are operating in terms of demand and capacity and the logistics of all of that, it's reasonably helter-skelter and reactive. Well, actually, you can start to kind of predict the whole flow, of kind of, patients and kind of demand and capacity, and you can and the kind of AI can really help with that. I think that's where the opportunity is. Clinically, right? I think the future is going to be kind of MDT based, and AI will be in the room. But again, I think clinicians will be in charge, which is what we'll always want. And it's, the MDT process will need to take precedence. Ethicists will need to be consulted, but it's going to be purpose specific. And the data and the bias kind of inherent in that will need to be made available at the point of design and delivery. And constantly reviewed. So now imagine that Pandora's box of governance that needs to be carefully constructed. So I wouldn't worry too much about that at this stage. There's so much low-hanging fruit that we can go for that we don't need to think about big philosophical things in the immediate, because the right people are, NICE are. I know kind of, the senior NHS management are. I know that kind of companies like us and our people who are working on it are thinking about these things. But why aren't we doing the kind of basic stuff really quickly right now?
No. I agree, and
I
I think
agree.
you're all right. The low hanging fruits is the admin, the clerical, non-clinical side of things, and there are lots of startups innovating in that space right now, right? From
Yeah,
registration, workflows, rotas,
all of that is easily doable and probably better doable than we can do as a
exactly.
human. It might be that it tells you, look, don't open up another surgical bed. There might be another opportunity because we can see
Yeah,
computer can see this
exactly.
and yeah. And last time we did this, there was a 50% chance of success. It's stuff like that where
Mhm.
I saw something the other day and I was fascinated. There was a if you think, do you know what the cow is? The old kind of dead terminal that's carried around in
Yeah,
wards, right? And yeah,
Oh yeah.
yeah,
and people are still sometimes taking notes on tissue paper and taking it back to nurse's station, right?
yeah.
I've seen these integrated headsets like the ones we've got on, right, that transcribe and generate a kind of response that goes straight into a record. Yeah,
Incredible.
Wow.
some of the EPR systems are conducive to that, and you could kind of write back into it. So stuff like that. Just imagine any moment of time that we can save a nurse or a doctor. Yeah,
Yeah.
even if it is to have 5 minutes just to breathe or a cup of tea or to kind of talk to a colleague saying, oh, interesting case last week, right? That's a good thing. So how much time can we save on that?
Okay.
Multiply that up across the region. That technology exists today. Yeah.
I know.
And then the startups I'm talking about, right?
Yeah. Can I just say something? A funny story. So one of our consultants in one of the old hospitals I used to work with dictates the ward round, but he never kind of goes around or kind of goes and corrects it. And like the plan is like so butchered, right? So he goes around, dictates it, smashes out the ward round. And when you're going back to see the jobs list on the ward plan, you hear like the most funniest stuff. And it does help, and I can see where it goes. But like some of the plans, it doesn't, it comes up with some obscene stuff because of typos and stuff like that. But no,
Yeah.
I think that the technology is incredible. This is a story that came
Yeah.
to my head right now as you mentioned it.
Yeah, and there is technology that really does that in a really sensible way, and the time saving, yeah,
Mm.
It's
is
amazing.
huge. And to have that information available to the patient, the clinician, the system, in real time, it's so important. Yeah.
No, definitely.
Yeah.
And yeah, I
Absolutely.
remember when I was a first junior, just like we didn't even have cows, we had paper notes. You're faffing around, you're going to the ward, you're kind of writing down what the consultant's scribing, and you're all over the place. Like it's the little stuff like this that's like we desperately need it, and there really are low hanging fruits. But Sultan, I want to thank you so much for coming on, sharing your journey. I think you have yet more incredible things to do and achieve, but thus far you've done wonders for the NHS and soon
No,
for
no,
BT.
don't say stuff like that. Look, people have done the NHS and people in industry are really committed. I mean, there are so many
Mm.
amazing people that we have in our country, and I think that the trick is, you mentioned this with the kind of how do we get to work together. That needs to be
Yeah.
thought through. And there's a couple
Mm.
of things I just wanted to mention, just because I think it's important. I think whether it's AI or anything else, right? Data is the kind of fuel that kind of drives the next kind of
Yes.
20, 30, 40 years in terms of how healthcare is designed. So I think the data architecture of the country needs a really good look at, and we need to make sure it's optimized, and there's some good work going on, but there's more to do. But also all of these technologies, applications and kind of networks and stuff, we haven't got the infrastructure.
Yeah.
People are
Mm.
leaving theatre block to make calls still, right? There's not spots in hospitals. 50% of staff think there's a issue around technology. So we need to invest in the infrastructure to make sure, that it's fit for the future. And
Yeah.
this is why BT is so interested in this. So if we can help to do that,
Yeah.
and kind of scale it, we are committed to that. Because I remember the pitch to me when I was kind of being thought about. Think about the Japanese bullet train; it runs on really good tracks. That's why it's good, right?
Yeah.
Yeah.
And with the way I've characterized it in my own head is our clinicians, yeah,
Mm.
and the tech are like Japanese bullet train, really good. But
Yeah.
infrastructure and if you like, the kind of underpinning change management capability is the tracks, and that's not good enough quite yet. So we all have to work together to do that. And without the infrastructure, all of this is just theoretical. So we've got to get
Yeah.
that right. Yeah, the connectivity, the infrastructure is clearly important. That's why BT and people like BT are really important.
No, I definitely agree,
Absolutely.
and I think that's a nice way to end this conversation. Thank you once again, Sultan, for coming on, and we look forward to sharing this with the world soon.
Yeah, look, have a great day, and thank you for your time. It's been a real privilege.
Nice,
Cheers.
nice. Thank you.